Thank you, Laura, and good afternoon, everybody. Can you hear me okay, Laura?
Ma'am, we can hear you, Dr. Bell.
Okay. So I thank you all for this opportunity once again. Do want everyone to know that we'll provide an update, but there is still a great deal of information that we don't have at this time, and we will provide information as it comes forward as quickly as we can and as completely as we can. So, for example, we've been given an estimate of the number of doses that we will receive, and and we understand now that it is quite limited in the very beginning. But as vaccine manufacturing increases, we know that we will receive repeated shipments on a regular basis, and we will be able to meet increasing demands as manufacturing increases. So everyone who wants to receive a vaccine in South Carolina will eventually be vaccinated, and we encourage very high coverage as our ultimate goal. But we will need to do this in a phased approach because of the limitations. We'll have to vaccinate those who are most vulnerable first. The ultimate goal is to save lives, and we mean by that all lives. But with initial limited supply, we have to protect those first who have a direct role in saving lives, and that is our goal. That we'll talk a little bit more about how we arrived at our recommendation for the initial supply. Want people to know that we are prepared for the vaccine distribution. DHEC has worked with fellow state agencies in developing our vaccination plan for the state. We submitted that plan to the federal government, and they approved that plan. We submitted an updated plan as we learned more, because this is an evolving situation, and the second version of that plan is also being submitted. In addition to that, we convened a vaccine advisory committee in September. That committee, that is broadly representative of state agencies, professional organizations, and private partners, has been meeting weekly and is providing recommendations to DHEC and to the state as to how the initial limited supply of vaccine could be used. And this is based on guidance from the CDC, from the ACIP, from the National Academy of Science. And so it's all evidence-based how we plan to use the limited supply of vaccine following those indications. On this past Tuesday, the CDC's Advisory Committee on Immunization Practices, also known as the ACIP, announced their recommendations and DHEC's Vaccine Advisory Committee has concurs with those recommendations, and we're working to adopt them for South Carolina circumstances. Jurisdictions may have variations in their resources, and even down to healthcare facility levels, there may be variations. And so we have to be flexible, and we may have to adjust our plans and our recommendations as we continue to learn more. But for this initial phase, phase 1A, DHEC recommends vaccinating the frontline workers in healthcare settings. These are the individuals at highest risk of contracting COVID-19, but they're also essential in preventing mortality. So this is our way of protecting our healthcare facilities and protecting our frontline healthcare workers first, so that they can protect the others. We also, as recommended, are prioritizing those in long-term care facilities. They're among the most vulnerable and at risk for severe complications. And so they'll also be among our first who are able to receive the vaccine. This is all based on the fact that there are very limited supplies, but at the same time, we are making plans for how we will make vaccine available in the later stages, even though we don't have those doses at this time. DHEC and the Vaccine Advisory Committee, we have draft plans for vaccine allocation for the later phases, but we won't be able to finalize those and release those plans until we have additional information from the ACIP, because they too are working in a phased approach with their recommendations. The next meeting of the ACIP is going to be held on December 11th. In South Carolina, we currently have 5 locations in the state that are capable of storing vaccine, which is required to be kept at an ultra cold temperature. And from the first 5 secure locations, the vaccine will be distributed to licensed vaccine providers who have successfully completed the required enrollment process that will allow them to comply with the storage and handling requirements and to administer COVID vaccine. And at this time, we have nearly 200 licensed vaccine providers across the state who've completed the enrollment process to administer COVID vaccine. And we continue to anticipate that South Carolina, like other states, will have these initial allocations of the vaccine before the end of this month. We also know that some people are skeptical about this vaccine. And we're fully aware of vaccine hesitancy, unfortunately, not just for this vaccine, but for all other vaccines. And we really understand why people raise these questions, and we want to make sure that people are well informed so that we can avoid any myths that create any barriers to people taking full advantage of being protected from this vaccine, or being protected actually by the vaccine. And so I want to take this opportunity to ensure everyone that the public's safety and the health of individuals is paramount to us. And this is why these vaccines exist. Vaccine manufacturers made a commitment that no vaccine would be introduced into the market that hadn't gone through the rigorous process that all vaccines go through. And all of the evidence that's been collected, all of the clinical trials, that evidence will be submitted to the FDA and will undergo that review that's required by the FDA for all vaccines. The process is just the same. I want to encourage everyone to continue to seek the information that's available from credible sources, from trusted medical sources, and avoid myths, misinformation, because that won't get us where we need to be. So we will keep the general public fully informed about everything that we're learning about these vaccines. And I want to remind people that the vaccine, it is ultimately the vaccine that's going to get us out of this pandemic, but these early supplies will not get us there soon enough. So I continue to remind people that we completely understand the great deal of interest in vaccines. We want to support that interest and inform everybody, but we don't want everybody to forget of the primary prevention measures that are available to all of us now. That everyone should have access to a mask. Everyone can practice physical distancing. And these are evidence-based effective measures in preventing the spread of disease. And also want to remind people that we're moving into flu season, so that there is another vaccine available that everybody should take, 6 months and older. Everyone should get the flu vaccine. To the extent that we can control flu is another measure to help us protect our healthcare systems and our healthcare providers, and to protect your own health as we move into flu season. And as our disease trajectory goes up, we're very concerned about the burden on the healthcare system, and we need to continue to use those primary prevention measures to fight the spread of COVID and flu. And so this vaccine will give us one great step towards that, but it will take us a few months to roll it out for everyone. In the meantime, we want everyone to understand the phases that we're going through and what they can anticipate. And so with that, Laura, I'm happy with my other colleagues to try and address any questions that they may have.
Thank you, Dr. Bell. And I failed to mention that in addition to Dr. Bell, we also have Dr. Jane Kelly, our assistant state epidemiologist, as well as Stephen White, our immunizations director, on the line. And so they, as well as Dr. Bell, I'll go ahead and begin reading out some of the most common questions that you all sent over for them to address. And so Dr. Bell, Dr. Kelly, and Stephen, the first 2 questions that we've been getting is, when does South Carolina expect to get our first shipments? And do we have any solid estimates of what that first allocation will be?
Stephen, could you take that question?
Sure. So I think that the timing, what we understand thus far is that we could see an EUA approval sometime for the Pfizer vaccine as early as December the 10th. As Dr. Bell had mentioned, ACIP will be meeting on December the 11th. So we are anticipating that we could see vaccines delivered to sites, the limited quantities that we will get, likely sometime in that December 14th, 15th, 16th timeframe is the time frame that we're looking for. And again, things can change, decisions could linger, things could be expedited, but that is the time frame that we're thinking that vaccine could be available if the EUA is approved and ACIP provides their guidance. As far as the number of vaccines, we do have some notional data. The problem with giving out a number is that this information has changed several times over the course of several weeks. And so we have an idea of the number of vaccines that we're going to get, and we're still trying to determine which reporting metrics we are going to be able to report out. Until you actually have the doses in hand, it makes it very difficult to say we're going to get a certain amount of doses. It is very limited at this time. We do plan that once we have the doses in hand, I do think that we will likely have some sort of transparency and ability to provide the number of doses moving forward, and as we get more doses down the line. Thank you.
Thanks, Stephen. On that same note, can you walk us through what an EUA is?
That's a great question. I actually had to go back and look at that yesterday myself just to make sure I had the correct definition on a CDC call, and they actually spelled it out nicely for us. So I will read out what I was able to find yesterday if I can actually find it. So an EUA is the authority of the FDA commissioner to permit emergency use of certain medical products under Project BioShield Act 2004. And so what it does is it provides the FDA the authority to approve unapproved medical products or unapproved use of an approved product for any kind of new indication. It's traditionally used for emergencies that are involving chemical, biological, radiological, or nuclear agents. And of course, it has to meet certain criteria such as serious or life-threatening diseases or condition, which certainly COVID-19 acts as one of those, serves as one of those criteria. And then, of course, it has to have also the reasonable belief that the product can be effective, and there has to be a known potential benefits that they outweigh the known potential risks, and also that no adequate approved available alternative is available. So that is the latest information that I have from CDC as of yesterday on the definition of an EUA. Thanks.
Thank you. And then another question for one of you to please answer is, can you briefly explain, we understand right now there are 3 phases, phase 1A, phase 1B, phase 2, and phase 3. Can you briefly give us an outline of what the phases are and what they mean?
Dr. Kelly, would you mind taking that question?
Certainly. In South Carolina, we formed a vaccine advisory committee, and one of the first documents that we examined was a framework for equitable allocation of vaccine by the National Academies of Science, Engineering, and Medicine. And in the NASEM document, they talked about phased allocation. And certainly everyone else is talking about these different phases of allocation, and these phases may be interpreted slightly differently among the different entities, but I think there are some generalizations that we can make. Phase 1 is the initial phase of vaccine allocation. That's the phase where we know there's going to be a very limited amounts of vaccine available. And so we had to think hard about who are the most critical people to vaccinate first to reduce mortality. And you heard from Dr. Bell about some of the decisions we made. Those decisions are compatible with the ACIP, the Academy of ACIP. Sorry, I'm just blocking on the Academy's, what that acronym stands for, sorry. It is consistent with the ACIP recommendations. So in phase 1, we've broken it, as have many others, into phase 1A and 1B. 1A, as you'd heard, healthcare workers and residents of long-term care facilities are among the people most at risk for mortality or prevention of mortality. So they are in that first phase. We are still working out the details of who belongs in the other phases, but I can give you a general feel for it. Phase 1B, which would begin once we have enough vaccine allocated to cover all those in phase 1A who want to receive vaccine. Phase 1B would be other people at increased risk of contracting COVID-19 or increased risk of having severe disease if they did become infected. Some of those are medical conditions or age-related conditions, in that we know that nationally 80% of the people who have died from COVID-19 are age 65 and older. So we know age is a big factor for severe disease. There are other categories, though, that have to do with exposure. For example, people working or living in other congregate settings, such as group homes, correctional facilities, who are at increased risk because of where they work or where they live. In phase 2, we hope we would have larger amounts of vaccine. Manufacturers right now are revving up their manufacturing of vaccine in anticipation of being able to meet the larger needs in early 2021. So phase 2 would be individuals who, again, are at increased risk, maybe not at the highest risk as those we included in phase 1A and 1B, but at increased risk because of their worksite setting, for example, working in school settings or colleges and university settings, or because of medical conditions such as diabetes, obesity, chronic obstructive pulmonary disease. There's a list of medical conditions on the CDC website that we are using, understanding that this list includes individuals with conditions that place them at increased risk for severe disease should they become infected. And then phase 3 is opening up to everyone who wants to receive vaccine. Our ultimate goal is that everyone in South Carolina who wants vaccine can receive vaccine, but we need to do it in this phased manner in order to cover the most vulnerable first. Some people also talk about a phase 4 being sort of a cleanup of going out there and encouraging people who haven't received vaccine, who maybe were hesitant in the earlier phases and wanted to delay, that we wanted to make sure that we have that final push to get as many people to receive vaccine as possible.
Thank you, Dr. Kelly. And just to be clear, and feel free to correct me, I think that, I don't know if other states have been referring to it. I know that we've been calling it that we're in kind of phase 0 now. So just to be clear, the vaccine is currently not available, so we're not quite in a phase 1 yet. And would one of you please address, are we expecting that the initial allocations would cover everyone who meets phase 1A? And if not, how will it be determined who that qualifies as a 1A individual will get the vaccine first?
Dr. Bell, would you like me to take that as well?
Sure, go ahead.
This is difficult because we do anticipate that we will not receive enough vaccine to cover everyone I just mentioned in phase 1A in the first week. And I think this is an important thing to keep in mind. We will receive an initial bolus, an initial amount of vaccine in that first week, but then there'll be additional allocations of vaccine on a weekly basis. So while we would not be able to vaccinate everyone in phase 1A in that first week, we would be able to as the weeks go on. So as we get more and more vaccine, we'll be able to get it to everyone who needs it. Some of those decisions about if you can't give it to everyone in that very first week, who would get it in that very first week, some of that relies on local conditions. For example, when I talk about providing vaccine to workers in healthcare settings who are taking care of critically ill COVID-19 patients, of course, that group is heterogeneous too, right? Some of them are working hands-on with these patients for hours at a time. Other workers in healthcare setting may be in a patient's room for only a short period of time. We're not going to make that level of decision making. Local decision makers will do that. We certainly have some guidance around how to, if you don't have enough vaccine, to vaccinate everyone immediately in the very first week. How do you determine which ones should be vaccinated earliest? Some of it may have to do with other medical conditions. For example, if you have an older nurse with diabetes versus a younger respiratory therapist with no medical problems, there might be a decision at that local level to vaccinate the more vulnerable person.
Thank you, Dr. Kelly. And do we have is there any way to anticipate at this time how long we may be in a particular phase, I guess especially phase 1A? Is there any time frame for that right now?
If you don't mind, go ahead, Stephen.
Well, I was just going to add to this question and just say that, really that's going to depend on allocations and how many doses we get over the course of the next several weeks to be able to fulfill our obligation to vaccinate all of those that are listed in phase 1A. So right now we have an idea that we're hoping that by early 2021, and so we're anticipating that based on the allocations that we're going to get in the coming weeks, that hopefully sometime in the January, potentially February timeframe, we may be able to move into a 1B type of status and start looking at those particular targeted populations. That's the idea based on the allocations. But again, things change and we could move into it earlier. This depends on how many we're going to get and what the ramp up is going to be from the federal government.
But Laura, I do want to make the point that it will be a transition, that people shouldn't expect that we will flip a switch and move from 1A to 1B. We will offer the vaccine as best we can, as supply allows, to those who are indicated for phase 1A. Well, for example, if some people are hesitant about getting vaccinated in 1A, we won't sit on inventory waiting to cover all of those who are in. We will strongly encourage people to get protected as quickly as they can, but if the uptake is not as rapid as we would like, then we will transition into phase 1B. We will continue to offer the vaccine to anyone who was not vaccinated in a previous stage, but don't want people to read too much into these phases as if they are marks on a calendar. It's a transition, and as Stephen said, there are many factors. Supply and acceptance are two of the main ones.
Thank you both. And so which vaccine is South Carolina expected to receive first, and how many doses will you need dependent on that vaccine brand?
So Stephen, would you mention that the fact that we will receive both products, just a few more details there. Thank you.
Sure. So we are, as I mentioned before, the timing as far as what we anticipate receiving the first vaccine brand will be the Pfizer brand, we anticipate. And as you are probably well aware of, Moderna has submitted their DUA for approval and review. And so it's anticipated that the second week, so the week after we receive the Pfizer vaccine, that we could receive the Moderna vaccine. So that would put us right before the Christmas holidays if we're looking at time on a calendar. And that's, again, an assumption based on review and approval of the EUA. Thanks.
Thank you both. We got a couple questions about providers. I know that we mentioned that we're close to about 200 providers in the state that have successfully completed enrollment to become a COVID-19 vaccine provider. Some of the questions we got are, who are these providers, where are they located, and how will we ensure the vaccine reaches people in some of our rural communities?
So we have given information about the total number of providers who have gone through the approval process, and this is statewide. We'll continue to encourage as many providers as possible. But in terms of reaching those rural communities, in addition to traditional settings where vaccines can be administered in hospitals, in ambulatory care settings, in pharmacy chains, to meet that demand and that need in rural underserved areas, we're also exploring all other possibilities for non-traditional sites in community settings. We will look at access to care, and in areas where there are a limited number of healthcare providers, we are establishing, we will make the vaccine available in our DHEC clinics, and in other potentially temporary sites where we may be able to offer mass vaccination clinics. And we are working to assure that in medically underserved areas that the vaccine will be available.
Thank you, Dr. Bell. We'll do a few more questions here. Another one we got is about the 5 sites that we mentioned that currently have ultra cold storage capabilities. Can you talk a little bit more? I understand a lot of folks have some questions about where those are located, and I hope I've conveyed to you all that providing that kind of detail about the location of such a limited potential supply of this vaccine has some potential security issues at this time. So while we're not necessarily providing the locations of those places with ultra cold storage now, can we talk a little bit about how the vaccine will be across the state, 5 locations?
Sure, I think I can handle that one, Dr. Bell. So yes, I mean, due to security concerns, and this isn't just a South Carolina concern. I've been on other state calls with other states about releasing their names of or the locations of where they're going to be sending the first initial vaccines. And in most states that I've talked to, I don't know of any state thus far that has released the location names of where those vaccines are going to go to in their limited supply. In time, we do anticipate that there will be a vaccine finder where patients will be able to see where they can go to receive vaccines in time, and this will likely be in a phase 2 time when we start vaccinating, mass vaccination, when pharmacies have it, et cetera. But getting back to the 5 sites that we're looking at in the state at the moment, we did take a good look around the state, and when we were polling our providers around the state to enroll, which we are continuing to perform outreach to our healthcare facilities around the state. We looked at who had the ability to store ultra cold storage, which ultra cold storage isn't necessarily a requirement to be able to receive vaccines. So to be clear, I know that's another question that's come across lately is, do sites have to have ultra cold storage vaccination capabilities? And the answer to that is no. These vaccines, while they long-term storage, must be stored in those ultra cold, frozen refrigerated units, or in a frozen refrigerator or freezer rather for Moderna. They can be stored in refrigerated temperatures for a short amount of time, and so you have to be very strategic with how those vaccines are going to be used if they're not going to be stored in those types of temperatures. So we looked at around the state, and we were equitable as far as selecting sites around the state that were able to handle first dose shipments. And so we selected at least one. We selected one site from each of the 4 regions of the state, which would be the upstate, the Midlands, the PD region, and the Low Country. And then we also selected a regional, a centralized distributing site where we would be able to provide vaccines to facilities that are not able to handle larger quantities of vaccine orders. Just as a reminder, the Pfizer vaccine comes in a 975 minimum quantity order, and the Moderna vaccine comes in 100 doses. So there were some logistics as far as how would we get vaccines to smaller sites if they didn't have the ability to vaccinate, because we don't want to waste vaccines. So we're looking at a centralized model to get to those sites. Thank you.
Thank you both. And Stephen, I know you have a 3:30 commitment, so if you have to hop off, we understand, but I will try to ask a few more questions here. A few more questions about the vaccine itself. A lot of folks asked, is the COVID-19 vaccine a live virus similar to the flu shot?
If it's okay with you, Dr. Bell, I'll take that one.
Sure.
The COVID-19 vaccines that we're talking about, the Pfizer and Moderna vaccines, are messenger RNA viruses. They are not live or attenuated or inactivated virus vaccines. They are very different from the influenza vaccine, and in fact are fairly different from any vaccine currently on the market, in that what they do is they don't start with a virus particle and then make a vaccine around it. In fact, they start with just a small snippet of the genetic code, the RNA of the virus, and then surround it with an oil coat. And that is what the vaccine consists of. When injected and taken into the cells when you're vaccinated, those cells then produce the little snippets of the spike protein, which is the attachment surface that the virus uses normally to get into your cell. So it cannot give you COVID-19 because it doesn't give you the entire DNA for the entire virus or the entire virus. It just gives you that little snippet for a protein. So your cells will make the protein, and then your immune system responds to that. And your immune system makes antibodies and what are called activated T cells, which are killer cells that will respond, so that if you're exposed to the virus, it will react to that spike protein, so the virus can't even get into your cells.
Thank you, Dr. Kelly. Another question that we have, and I know, Dr. Bell, you mentioned it briefly in your updates, in your update that you gave at the beginning of this session, but can we talk a little bit more about, skepticism with this vaccine, what we've been calling vaccine hesitancy? We're working to help address that.
Yeah, sure. And in simple language, we want, as has already been said, that the development of these COVID-19 vaccines has been no different than any other vaccines. And they have gone through the same initial research and development, the same clinical trials as do other vaccines. If I could, I'd like to put in sort of a different context the way people think about vaccines, and the fact that not only all vaccines, but all medications, including over-the-counter medications, can have some side effects, and there can be some rare adverse events. But what we expect for most vaccines, as we do for the COVID-19 vaccines, is that there could be some symptoms associated with getting a shot, that it can include generally a sore arm, maybe feeling a little bit achy, a little bit feverish for a day or so. But those should not be interpreted as the vaccine is not safe because some of those symptoms occur. These are true for other vaccines as well. There is we look at the risk and the benefit, and people tend to pay more attention to myths and even the small risk that could be associated with a complication from the vaccine. I don't feel that people pay attention to the potential complications of other medications as they do for vaccines. In fact, I'll just mention briefly, if you read the package insert for Tylenol, I think people would really be alarmed about the association with liver failure with Tylenol and things that we take for granted every day. But that is not to say that these vaccines have not been shown to be safe and effective for COVID-19. And what we really want people to pay attention to is the risk and benefit of the risk of being exposed to the disease while disease rates are so high, and the benefit of being protected. And that's what we want people to focus on. So the risk of having a sore arm, feeling a little achy, maybe a little feverish for a day or so, and experiencing these temporary symptoms with the benefit of potentially being protected from severe illness, hospitalization, and even death. That's what we want people to pay attention to, and that's why vaccines have been so effective in reducing the rates of vaccine-preventable diseases. And as they are one of the most effective public health interventions historically, it is their success in making vaccine-preventable diseases go away that people have forgotten about the severe consequences of vaccine-preventable diseases. And we don't want anybody to miss the opportunity to combat what we're experiencing now with COVID-19, because it is high vaccine coverage that will be our way out of this pandemic.
Thank you, Dr. Bell. I do have about 3 more questions. One segues, Dr. Bell, what you just mentioned segues into the next. Once an individual receives the vaccine, does he or she need to stop wearing a mask and stop social distancing?
Would you like me to take that then, Dr. Bell? This is a very important and insightful question. Even a vaccine that is 90 to 95% efficacious, as we understand from the information released thus far, we understand that these 2 vaccines coming up are that efficacious, that effective. Even 90 to 95% means that 5 to 10% of people, the vaccine is not going to stimulate their immune system. They will have received the vaccine, but they won't be immune, and they won't know it. We won't know who those people are. So, for example, if you get the vaccine, you may be protected, but the person next to you might not, and they don't know it. For this reason, we still recommend, and CDC recommends, that you continue with those mitigation methods, meaning wearing masks, keeping your distance, washing your hands frequently, because number one, even after you've been vaccinated, you're not 100% sure that you're covered. And number two, we don't know yet to what extent this vaccine prevents transmission. And by that, I mean it's possible that you get your vaccine, you're immune, you get infected, and you don't get sick. You just get asymptomatic infection that might spread it to someone else. So, as we've said so many times, there are still some new things to be learned about these vaccines, and we want to play it safe. So even after one has received both doses of vaccine, we recommend, until we have a high coverage of a large number of people in the state vaccinated, that you continue to play it safe, maintain the gains, wear your mask, socially distance, wash your hands.
Thank you, Dr. Kelly. Another question, maybe for Stephen to answer, if you're still with us, is how are we going to track vaccine allocations or administrations? How will we know that the correct people, based on which phase we're in, are actually receiving the vaccine?
Yeah, so I am still here. I do have to drop off here in a minute. But as far as tracking the vaccines and ensuring that the right people are getting it, so we are going to be using federal systems to track the allocations, and those allocations, as we are providing allocations to providers to administer those doses, we will be administering those providers will be administering those doses into a federal system, which we're going to call, it's called VAMS. It's a Vaccine Administration Management System. It's a CDC developed system with a company called Deloitte. They contracted with them and Salesforce, Sales Solutions. And so we will be utilizing that system along with many other states using that system, and they will document in that software solution that a person received their vaccines. At the same time, they will be they will be asked to go ahead and set up their second appointment for their second shot, given that time frame. They will also be given a second dose reminder along with a reminder shot card, which will come with the ancillary supplies that comes with the vaccines. And so a provider will be able to provide that shot card that people are used to getting when they go to the doctor's office, in addition to that. And as far as reporting that, those doses will go into our state registry, where all vaccines that are administered must be reported to the registry within, for this vaccine, it will be between 24 to 72 hours. Thank you.
Thanks, Stephen. And I did have just one last question. South Carolina, like many other states, are of course following federal guidance in regard to the vaccine, whether that's from FDA, the CDC, the White House. But how are we making sure that we're making South Carolina specific decisions that are in the best interest of our South Carolinians? And I think if you all could talk about maybe what the Vaccine Advisory Committee is, might help answer that question.
Sure, Laura. We did convene the Vaccine Advisory Committee beginning back in September, and our goal was to make sure that we had representation from state agencies, from healthcare providers, from the business community, and also from organizations and private entities that represent disproportionately impacted populations and others. And we have met on a weekly basis, as Dr. Kelly mentioned, to visit the available evidence and guidance about how the vaccines should be used. And in those discussions, each week we have worked on a couple of primary things. One is public education, making sure that we have information available for healthcare providers. As with any new vaccine, provider education is a very important component so that they can make those recommendations to their patients. We also want the public to understand, as I said, what to expect. Information about the vaccine itself, but also about our plans as to how we're making it available, and to give them that reassurance that we've already talked about for the vaccine. And in addition to that, we have used that body to obtain feedback from the various constituencies that all of the Vaccine Advisory Committee members represent, so that they can help us look at potential pitfalls, certain things that we might not be thinking about in our planning. How will we best roll out the availability of the vaccine in the later stages, so that we are simultaneously making plans for all of the different phases, and we are taking into special consideration the fact that in South Carolina, where we have a large proportion of a rural population, a large proportion of minorities and individuals of color who historically have had issues with access to care and other socioeconomic factors and things like that that put them at increased risk for having comorbid conditions, that we have worked very hard to address all of those issues to make sure that we're providing education about who's at risk, providing education about why we are having to make the decisions that we're having to make at various stages. And I just want to emphasize that the consideration with making sure that all are served ultimately has been one of our highest priorities of the Vaccine Advisory Committee. And they have served in a role to advise the State Emergency Management Division, our other state agencies and partners in planning, as well as the agency leadership, about what we should be thinking about to plan as early as we can to maximize uptake for the vaccine as soon as vaccine supply will allow at all the various stages.
You or Dr. Kelly even have any final comments to go ahead and give them now, and then we'll go ahead and wrap up. And any questions we didn't get to, I'll work to respond to y'all via email. But any final comments, doctors or Stephen?
Well, I do want to make one final comment, because we are have just celebrated the Thanksgiving Day holiday. We moved into that holiday with disease rates that were much higher than we had seen prior to other holidays. And we believe, as we're seeing nationally, that we are unfortunately probably going to see the consequences of some of these holiday gatherings. So what I want to remind people about is, again, I just want to give this resonating prevention measure, that we're excited about the vaccine. This is a fantastic opportunity for all of us. But in the meantime, until we can get high population coverage that is not going to come to us probably until the spring, that in the meantime, we have to do some immediate things to prevent new cases of COVID-19. And that is the fact that masks do work, that masks have been very effective in controlling spread. Our own DHEC studies have been posted, that we've looked at the comparison of jurisdictions that have mask ordinances in place and those that do not. And we, along with other evidence that was recently published by the CDC about the effectiveness of the widespread use of masks in community in turning disease trends around within a matter of weeks, if we all pay careful attention to those measures of the use of masks, physical distancing, avoiding large groups, being careful even in your family gatherings where we are seeing the greatest number of the clusters of cases is within households. There's about a 50% risk of transmission within households. That if we take to heart all of those measures that are available to all of us now, in the matter of about 4 to 6 weeks, we could see a different trajectory in South Carolina than what we're seeing in other states. We could avoid that impact on our healthcare facilities and on our healthcare workers. And I really hope that everyone will take this to heart to do what we can now to reduce the impact of COVID in our communities.